Today, I have the pleasure to introduce you to Dr. Ron Fields, Medical Director of St. Mary Medical Center Heart and Vascular Center. He is also the recipient of the Philadelphia Magazine Top Doctor Award for the last 14 years. I'm your host, Margie Zimmerman, and this is Beyond the Stethoscope. Thank you for joining us today, Dr. Fields.
My pleasure. Thanks for having me.
So today we're talking about heart disease, and I was wondering if you could tell our listeners all about heart disease and how common it is.
Heart disease is a very general term. I like to compare your heart to your house. It has different components. It has its electrical system that controls heart rhythms. It has the plumbing, like the heart arteries. And just like in your house, the electrical system and the plumbing have nothing to do with each other. Has the valves, which act like the doors between the rooms, and then the structure itself, like the foundation of your house. You have the heart muscle itself. So heart disease is a very general term. You could have rhythm problems, coronary artery disease, valve issues, or just a weak or diseased heart muscle without any of those. Many times they occur in combination. Heart disease, most of the time we're focusing, I think, especially for today's talk, is coronary artery disease. That's what often people think about, and that's the plumbing of the heart. It's still the most common cause of death in men, and unfortunately now it's also the most common cause of death in women. In fact, this is Heart Month, so we're paying a special attention to women.
What is the difference between angina and a heart attack?
Angina is the symptom you feel if your heart muscle isn't getting enough oxygen. It occurs when the arteries are narrowed from the buildup of plaque within the arteries, and it's generally a pressure feeling in the center of the chest. People are often asking, have you had any chest pain? It's almost never a chest pain. Discomfort has too many syllables. So we say pain, but we really mean pressure, tightness, achy. It can vary from person to person how they feel it. The pressure in the center is most common, but it could be off to the side. It could be up in the neck. It could be sharp or indigestion-like. Indigestion is not uncommon. A lot of times people think they're having indigestion when they're really having angina symptoms. So angina is going to come on when you exert yourself. If the artery is narrowed, heart muscle is not getting enough oxygen. When you exert yourself, demand for oxygen goes up. If demand outstrips the supply, that's when you'll feel your angina symptoms. So while you're doing something active, this will come on gradually, and then when you stop, it'll fade away over a few minutes. It won't be seconds. It won't be hours. It won't be while you're just sitting there. If you were having angina just sitting still, then that artery is so critically blocked that sitting still, your heart's not getting enough oxygen. If that was the case, every time you walked around, you would have much worse symptoms. So be suspicious for any discomfort, no matter exactly what it feels like or where it is, but the timing is key. If it comes on when you're exerting yourself and goes away when you rest, that's heart till proven otherwise, and you need to see a doctor to look into that. A heart attack is different. A heart attack occurs when an artery closes off completely, usually from a clot forming on it. That's why people take aspirin. So a clot forms, and that can happen anytime. It can happen when you're in sleeping. And at that point, the artery is completely shut down. The discomfort's much more severe and won't go away in a few minutes with rest. It's not going away till you get to the hospital and get emergency treatment.
Do you recommend that people take baby aspirin or aspirin, like just as a precaution?
The answer for that's different this year than it was last year. So in the past, we basically told almost every adult, especially if you had any risk factors, probably better off to be on a baby aspirin. But just this last year, they published 3 different studies looking at people who don't have any vascular disease, heart disease, carotid disease, peripheral disease, no known blockages. And they took people who were either over age 75, or they took people who had a couple risk factors, or they took people who were diabetic, 3 different trials, but no known vascular disease. Half got aspirin, half didn't. There was some less strokes and heart attacks in that group, but aspirin does have a risk of bleeding. It's not common, but they found in those groups, if you don't have blockages, the risk of bleeding outweighed the benefit. If you have blockages, then the benefit outweighs the risk. There's still risk of bleeding, but the reduction in heart attacks and strokes outweighs that risk. So in the last year or two, since these studies came out, we've been taking a lot of people off aspirin who previously were taking it.
Okay. If a person experiences that tightness in their chest, they're not exerting themselves, but they're sitting there, and every now and then they experience that tightness in their chest, is that something that they should be concerned about?
Generally, if it's random, it's usually not going to be the heart. It may be acid reflux. It may be coming from soreness in the chest wall. Your chest wall is made of muscles and tendons and ligaments and cartilage. You
So
can
it
have
doesn't
soreness
mean
in
that
any of them.
arteries are like it's
Right. You can't feel the artery
Okay.
clogging at all. There's no sensors and no nerve endings inside your arteries. When we do an angioplasty, people can't feel that. You feel it if the heart muscle's not getting enough blood flow.
okay.
So till that happens, you won't have any sensations.
Okay. Thank you for clarifying that. Are the symptoms different between, I guess, angina and a heart attack?
It's generally a degree of severity. Your angina might be different than mine, might be different than that person's, whether it's pressure or achy or burning, chest or jaw sometimes, but yours is yours. You won't vary. You won't have pressure one time here, achy one time here, sharp one time here. Yours
So
is
it's
yours.
usually the same.
Yeah, what differs is severity. And a heart attack was also, if you're exerting yourself harder and the heart's not getting enough oxygen, the sensation will be stronger or might start to spread out more. And then with a heart attack, when it's really not getting enough oxygen because the artery's completely closed to that part of the heart, the same sensation, just much more severe and likely to spread out more. So it's a matter of severity, not a matter of different symptoms.
And thank you for clarifying that. How can we lower the risk?
It's important to pick the right parents. Let's start with that. After that, then there's only a few things we can
I'm
modify.
not lucky there then.
So genetics play a big role, and I'll discuss it in just a moment. But it's cholesterol that makes the plaque in your artery. And there's a common misunderstanding that plaque doesn't form on your vessel wall. The cholesterol particles that are floating in your blood have to cross the inside lining of the artery, get into the middle layer, and that's where the plaque forms. So it's not in the artery, it's in the wall of the artery. So plaque can't break off and travel downstream. It's in the wall of the artery. And if it's all cholesterol that makes up the blockage, why do smokers get more heart attacks? There's no smoke in plaque. Why do diabetics get more heart attacks? There's no sugar in plaque. What they do is damage the lining of the artery. That lining, called the endothelial layer, is a very active organ. It makes enzymes and proteins that help keep our arteries healthy. Sometimes it doesn't work properly. Smoking damages the lining. Diabetes, high blood pressure, all damage the lining to let the cholesterol cross that lining, get into the middle layer where the plaque forms. So that's where those other risk factors play the role. You need cholesterol to be high, but you need usually something else. Sometimes that something else is genetic factors we don't understand yet. We know, obviously, if you have family history, you're more likely to get it. But what genes do that? It's not going to be a single gene. They would have figured that out already. It's going to be the interaction of several genes, and not probably just one group of genes, but of multiple ones. If you have 3 of these 5, for instance, then your arteries are more susceptible. Not only do we not know what genes, we don't know what those genes are doing. A lot of times they'll figure that out first. That yes, these genes are making an enzyme that makes your arteries more susceptible. We have no idea there. What the genes are doing, we just know clearly it's a factor because there's such a strong family history that gets involved. So the main thing, till we figure out how to change our genetics, someday we probably will, is to make sure you address your risk factors, that you're seeing your doctor for regular checkups. Your blood pressure is good, your cholesterol is good, your sugars are good. Eating healthy and a healthy exercise help indirectly. They don't make your vessels better, but they lower your blood pressure, they lower your cholesterol,
Yes,
and
all
lower
that
your
is
sugar.
better. And how about the calcium scoring test? Does that help to find out if you have a
That's
lot of
something I
plaque in
think
your
that's
arteries?
underutilized a lot. So a lot of times patients come to us, they have a family history of heart disease, so they're worried they may have high blood pressure, and they're worried, how do I know if I have a heart problem? Should I get a stress test?
Yeah.
First question is out of their mouth. And the answer is no, you shouldn't get a stress test for that. Stress tests do not see the heart arteries. Stress tests see, is your heart muscle getting enough blood flow? Whether it's a regular stress test or a nuclear stress test, there's multiple forms of stress testing, but none of them see the arteries. You see, is the heart muscle getting enough blood flow? There's a lot of reserve built into your arteries. So unless a blockage is severe, it's not going to show up on the stress test. So it's a great test if you're having symptoms that we think might be your heart. If you're having chest pain, if you're having shortness of breath, and again, pain in that very general sense, then there's a symptom that we think could be cardiac. Stress test is perfect for that. If the stress test is normal, it's probably not your heart. And even they would say probably because it's indirect, doesn't see the arteries directly, it's wrong 10% of the time. And if someone's having no symptoms and you get an abnormal stress test, the chance that it's a false positive test is even higher. Because they'll say, well, why don't you just do it? Well, if you do it and someone's having no symptoms and it's abnormal, next step is now you're doing something invasive. You're doing a catheterization. And it turns out may have been a false positive test in the first place. You don't do a stress test unless there's a reason to do a stress test. In the past, we were kind of stuck. That's all we had. Stress test of abnormal catheterization. But as you alluded to, there's a newer test called coronary calcium score. That's a perfect test for someone, family history. Am I starting to get any blockages in my heart? When plaque forms in the arteries, after it's there for a little while, the plaque gets calcified. You can see those calcifications on a CAT scan. In the past, you couldn't. Because the heart was beating, on a CAT scan, your heart would be a blur. About 15 years or so ago, CAT scans evolved. Multiple processors, faster processing can take out the blur. So now you can see those calcium deposits. It's not an angiogram. It's not going to tell you you're 10% narrowed, you're 50% narrowed.
Oh.
It's going to give you a score. A normal coronary calcium score should be 0. There shouldn't be any calcium in the wall of the artery because it's only there if there's plaque in the wall of the artery.
Okay.
So if your coronary calcium score is 0, your risk of a heart attack in the next 5 years is less than 1%. Great test if someone has, and we see this a lot, mildly elevated cholesterol. Do I really need to take medications for the next 50 years of my life or whatever your time frame is going to be? And this can sort that out. If your score is only mildly elevated, if your cholesterol is only mildly elevated and your score is 0, we say no, don't take medications.
Good to know.
The risk of side effects from medicine outweighs the benefit. Your score is high, you're starting to form plaque. So anything above 0 is abnormal. And people use different numbers for different cutoffs. People say moderately high is 50 or 100, over 100 is moderately high. Over 400 is considered very high. In fact, if you're over 400, we recommend you get a stress test. Because statistically, you might have blockage bad enough to show up on the stress test. But I have seen people score over 1,000 with normal stress tests. There's lots of plaque there, but none of it is severe enough that it's narrowing the blood flow. So again, the stress test tells you, is the heart muscle getting enough blood flow? Stress test is normal, even with a high score. Yeah, treat your risk factors very aggressively. Get your cholesterol as low as you can, eat right, exercise, the things we've talked about. But not every calcium score means you need a catheterization or you need a stent.
What's involved in getting a calcium score test? Is it simple? How long is a procedure?
The insurance companies can be difficult.
Yeah. I don't think they cover that, do they?
Insurance companies have decided not to cover this. From the time it came out, St. Mary's, like many hospitals, has been terrific about this. Very generous. They charge $125 for the test. Again, it's not covered by any insurance company, Medicare, anybody. And that cost covers the hospital fee, the cardiology reading the coronary calcium score, and the radiologist reading you see lungs. Sometimes we have found a few lung cancers getting coronary calcium scores because you see the whole chest. And it's $125. So that the hospital, we're really thankful that they've been supporting that because they know the insurance companies haven't done it. And you just have to you can't just go do it on your own. You need a prescription from your doctor. It can be your family doctor. Some of the family doctors are comfortable ordering them. Some say if you're thinking about doing it, just see the cardiologist and let them order it for you.
And is it a long procedure or is it?
Yeah, it's about 10, maybe 15 seconds.
Oh, that's fast. That's the best kind of procedure
There's no
that I
needles.
like.
Yeah, no needles, no IV, no dye. You lie on the table, you take a breath in, and the camera shoots around you with literally about 10 seconds, and you're
That's
done.
great. That's
And
great.
then we give you a call with the reading.
Definitely going to get one of those. Well, you mentioned you would assess someone having symptoms, but is there a way to detect heart disease at any age before symptoms develop?
This is that coronary calcium score again.
Oh, okay.
It's really the only way to early detect coronary disease. Once in a while, we find patients coming to us because they got a chest X-ray or a chest CAT scan, and as an incidental finding on those studies, they saw calcifications on the heart arteries or on the wall of the aorta. The radiologist didn't always report that in the past, but now they realize that's important because if there's calcification, there's plaque. So doesn't quantify it like a coronary calcium score. You won't get a 10, 100, or 200. You'll just say, we can see calcification in the wall of the arteries. Go see your doctor. And then sometimes we'll get that calcium score to try to get a sense how much is really there. But short of that, there is really, EKG, I should say, once in a while will show abnormalities that make us suspicious for heart disease. If you have an abnormal EKG, that would be a reason to do a stress test if there's significant certain kinds of abnormalities on it. But short of occasional showing up on an EKG, incidental finding on a chest X-ray, there is no other good early detection except for the calcium score.
Okay. I just had a question. What is congestive heart failure? When someone, because I hear people and they have that, but they seem fine. So what exactly is that? What does that mean when someone tells you you have congestive heart failure?
Different problem than the coronary disease. Now we're talking more about the heart muscle. Congestive heart failure means fluid is backed up into your lungs. Generally, it falls into two categories. It's backed up because pressure is building up inside your heart, and it may be building up because your heart is damaged, either because you had a prior heart attack or there are some other reasons that the heart muscle itself may become damaged. The heart's now weak. The pressure builds up inside the heart. The pressure backs up into the lungs, can make you more short of breath when you walk. And if enough pressure backs up, fluid starts to fill within the lungs. That's congestive heart failure. Half the people who have congestive heart failure, however, don't have a weak heart. They have a stiff heart. It's called diastolic heart failure. And the term I always have to explain to folks because they always give me a funny look, just like that.
I'm giving you.
The diastolic heart failure is easy to understand. Think about inflating a balloon. You know how some are soft and pliable, you blow in, they stretch very easily? Mm-hmm. Others are real stiff. You have to blow hard to stretch the balloon open. Well, diastolic dysfunction is like that stiff balloon. Walls have become stiffer. It takes more pressure to fill the heart up with blood. It's not weak. Once it's full, it pumps the blood out fine. But that high pressure it's taking to stretch the heart open to fill with blood in between each beat, the pressure transmits back into the lungs, can make you short of breath, and if it's bad enough, causes fluid to build up in the lungs, congestive heart failure. So there's systolic or diastolic, weak heart or stiff heart. If you're in the hospital acutely with congestive heart failure, there's fluid in your lungs now, that's acute congestive heart failure. If you had heart failure, but now it's treated, there's a number of different medicines that can make the heart stroke
to make it better.
Sometimes patients get frustrated with us now. Acutely, we give them Lasix to try to get rid of the extra fluid. But we knew of one medicine, and then over these last few years, there are now 4 different classes of medications that all can help congestive heart failure, whether it's a weak heart or it's a stiff heart. So we're giving some, and guidelines are be on all 4 of them, at least 3 of them, if most of the time.
At once?
Yep. So we start them like one at a time and keep adding to it because if you're on all of them, it significantly lowers the chance of the heart failure coming back. Congestive heart failure for people discharged from a hospital, CHF, congestive heart failure, is the single most common cause for readmissions to a hospital of any diagnosis, period. Yeah, at once, often comes back. The medicines, unfortunately, some of them are brand name drugs, so they get, some patients get a little frustrated. They say, I have to take all these medicines, and some of them are brand name drugs, depending on their insurance plan.
Pay for
it's
them.
A lot of pills. It can be a lot of expense. They're almost always covered, but insurance plans vary a lot what the copay is going to be for a brand name drug on this plan versus that plan. So it's important to be careful when you're picking your insurance plans. That Part D, if it's Medicare or if it's commercial, usually there's copay cards, which you can't use for Medicare for unknown.
Sometimes it's so confusing for people to read those plans too. They
Oh,
don't
for
realize
sure.
it
To say
when they when they get it, and then afterwards they realize it doesn't cover what they need it for.
what they needed last time. So sometimes you have to be careful. Don't just necessarily pick the least expensive plan, but if you know you have some heart problems or these kinds of problems, you often know you're probably going to wind up with brand name drugs as part of your program, and try to pick one that has better brand name coverage.
Thank you.
I didn't mention, let me finish the congestive heart failure. One more thought. As you say, they can seem fine. So when your heart failure is compensated, there's no fluid in your lungs. You still carry the diagnosis of congestive heart failure, similar to, say, you have hypertension. I give you medications, your blood pressure is normal. You still have the disease hypertension.
Okay.
So this would be, you have congestive heart failure, you're compensated, it's not just chronic. You're not in heart failure right now, you still carry the diagnosis of congestive heart failure. So a bit of a semantic thing.
But with the proper medication,
You can,
you can help to treat
yes,
it.
you can make the heart stronger, you can lower reoccurrences. We give them certain things to follow at home by following their weights and looking for early signs of fluid retention. Yes, there's a lot of work.
How can they check to see if they have fluid retention? Is there a way that someone could check that at home?
In general, you could look at your ankles. If you just wanted to see out of the blue, ankles and the area above your calves, if you can push in and you get an indentation, there's usually fluid there. What we do for our heart failure folks is we tell them to weigh themselves every day. Get up, go to the bathroom, get on the scale, same way every day. And if you gain more than 3 pounds in one day or 5 pounds in a week, you're probably retaining fluid. Take an extra dose of your water pill those days till the weight's back down. And doing that has dramatically decreased readmissions to the hospital. Catch it early before it's so bad that you have to go to the emergency room.
Really? So they can actually take another dose of their medication if they see that they've, oh, I didn't know that. Oh, interesting. Thank you for this information. For those who have a family history with heart disease, what is the best course of defense to lower the risk of history repeating itself?
Similar to the questions that people come in, and my parents, what do I do to, how do I check myself out? So the key is really to address your risk factors if you have them. So get a full physical from your primary care doc. Not everyone with a family history has to see a cardiologist. This is right up the alley for the primary care doctors.
Yeah,
This
what
is
should they
what
look
they
for?
do. They're going to check their blood pressure, check their cholesterol, check their sugars. Those are really the three main things. And on top of it, you, like all of us, want to eat healthy, want to exercise, control our weight, because of the downstream effect of those things helping with the cholesterol and blood pressure and diabetes.
So if you have high cholesterol, you could probably bring it down if you start to eat better, exercise. But I know there's some people that they still struggle with
Most people with high cholesterol, it's not their diet. Basically 100%. If your diet's good, if you metabolize cholesterol well, you can have a bad diet, your cholesterol is going to be okay. It's just maybe higher in the normal range, but still be in the normal range. Cholesterol hyperlipidemia is a metabolic disease. You're not metabolizing cholesterol properly, and there's different forms. Some people make too much. Some people reabsorb too much from their gut. Some people don't break it down quick enough. All of those lead to high cholesterol. When we put someone on a low cholesterol diet, an exercise and weight loss program, on average these days, you only get about a 5% drop.
Really?
The reason is, for most people, the diet's not like it was years ago. For a while, people ate meat and potatoes every night for dinner, bacon and eggs every day for breakfast. Well, most people don't do that now. They have meat occasionally, have more chicken and fish, bacon and eggs and sausage, a little less often. So there's not as much room to change in the diet compared to what was 20 years ago. Because of that, their problem is usually they're making too much. It's going to help. It's going to lessen the amount of meds. And for some people, that's all they need, especially if their diet was bad to begin with. But the diet, exercise, weight loss, for some people will get them if you're close. But often you want that and medicines. You just won't need as much medicine if you follow the healthy lifestyle.
It's better. So is there an age range or specific condition that it would be beneficial to seek cardiac care even without a diagnosis?
No, you really don't need to see a cardiologist unless you're having the symptoms of shortness of breath, chest discomfort, or palpitations. Could be signs of an abnormal rhythm, wouldn't be a sign of a coronary disease. But unless your family doc sees something wrong, there's something that you have more than the average risk factors. Your EKG is abnormal. We're happy to see people just because they're concerned with it. They have their family history and they would like to do everything, but really, we're not going to do a stress test for you. And you can't hear blockages. So having a cardiologist examine you versus your primary care doctor examining you, doctor or nurse practitioner for primary care, we're not going to hear a blockage. So it's number of risk factors you have, including the family history, EKG, symptoms you're having. If any of those things are off, they'll often send to the cardiologist to check. But good primary care physicians, providers, can handle just about everything up to that point before they get heart disease.
So how about catheterizations? Like, when does that come into play? Like,
We got rid of those years ago. As the director of the cath lab, I had to say that. So the catheterization is generally to see, it's an angiogram of the heart arteries, usually done from the radial artery, sometimes still from the femoral artery, where you do an angiogram of the artery and see, is there any blockage in the arteries there, and is it enough to require a stent? Generally, it's done if someone has an abnormal stress test. We will skip the stress test if someone comes to the hospital with chest pain and their blood test shows that they had a heart attack. We don't need to do a stress test there.
So you would just go, that's when you
to
would
the catheterization.
right to the cath lab to do that.
There's a particular type of heart attack called a STEMI. It means you come in with significant chest discomfort, type of heart attack. Stands for ST segment elevation MI, STEMI. So you see that, and there's a classic EKG change if you have that. So if someone comes in the ER with chest pain, first thing they do, and it has to be within a certain 10 minutes, have to get an EKG. If it shows a STEMI, cath lab team is activated immediately. Middle of the night does not matter, with the goal of getting you up there and the catheterization started within 30 minutes, even at 2 o'clock in the morning. Because when you see STEMI on the EKG, it means the artery is completely closed off and heart muscle is dying. So there is a STEMI team 24/7, 365 that can be activated with one phone call. Everyone's beeper goes off. Everybody rushes in if it's off hours during the day.
Is that common, those type of?
Fortunately, not as common as it used to be. It's still a couple cases a week of people coming in with STEMIs. But I think the better management by the whole community, the primary care providers, the cardiologist, more aggressive cholesterol, better sugar control. Years ago, they lowered guidelines for what blood pressure should be. All these things seem to have lowered the number of heart attacks that we're having.
Thank you, Dr. Fields, for joining us today and sharing this valuable information with us, all about heart disease. And I myself have heart disease in my family, so I really appreciate you answering some of my questions. I'm sure we have a lot of listeners out there that are also going to be fascinated by everything you had to say. So thank you again for joining us. It's been a pleasure.
My pleasure as well. Thanks for having me.
Thank you. If you have a family history or any signs of heart disease, always consult with your physician. Thank you all for joining us today. Please stay tuned for future episodes of Beyond the Stethoscope.